Public health has early roots in antiquity. From the beginning of human civilization, it was recognized that polluted water and a lack of proper waste disposal spread communicable diseases. Used to call it the theory of miasma. Early religions attempted to regulate behaviour that specifically related to health, from the types of food eaten to regulating certain indulgent behaviours such as drinking or sexual activities, and the leaders were responsible for the health of their subjects to ensure social stability, prosperity and maintain order. By the Roman times, it was well understood that proper diversion of human waste was a necessary tenet of public health in the urban areas. And the ancient Chinese medical doctors developed the practice of variolation following a smallpox epidemic around 1000 BC. An individual without the disease could gain some measure of immunity against it by inhaling the dried crusts formed around the lesions of infected individuals, in other words, an early form of vaccination. At the onset of the Industrial Revolution, living standards in Britain began to worsen, with cramped and unsanitary urban conditions. Rapid urbanisation exacerbated the spread of disease in the large conurbations that built up around the workhouses and factories. Even the Isle of Man had a significant outbreak of cholera. The first public health institutions were set up in the 1840s, and work on the health of towns progressed at a fast rate, and in 1875 various public health acts came into force in the UK and subsequently in the Isle of Man. These days public health has moved a long way, and it's now defined as the science and art of preventing disease, prolonging life and promoting human health through organised efforts and informed choices of society, organisations, public and private communities and individuals. Analysing the health of a population and threats is the basis of public health, and the recent report published by the Ireland's Director of Public Health does just that. To discuss and to explore some of the issues raised in the report, the first since 2004, we welcome our studio guest. Its author, the Director of Public Health, Dr. Henrietta Ewart. Thank you for joining us.
My pleasure.
Well, there we are. A little bit of a background. First report. I was saying to you before we started the programme that I've actually found it, in comparison to some government's reports, which seem to be written in another language, this one seems to be a very simple one. It's a lot of little diagrams and pictures and simple paragraphs. I mean, it's a simple way to me of expressing what I seem to be, when I looked into it, a very complex subject.
Yes, and that was really our intention. It's very easy to write lengthy reports with lots and lots of dense text and maybe some very mathematical tables with a lot of statistics, but people don't read it, is the bottom line. They don't read it at all. If they do read it, it's so complex that they don't get the messages from it. So we really wanted to go for exactly as you've said, a very simple, very graphic presentation of the key issues around the health and well-being of the population.
Now, you called it a healthy island, but when I read the report, in places it didn't seem that healthy.
We called it a healthy island ? We were asking ourselves the question because, as I say, prior to our being able to produce and publish this report, there have not been any statistics that gave the overview of the health and well-being of the island, that they just weren't being collected, they weren't being analysed, they weren't being published. At best, people would extrapolate from the figures for England. And as we've seen from this report, sometimes our figures are like England, sometimes they're worse, sometimes much worse, sometimes they're better, much better. So just to assume that we're like England and extrapolate an England figure to our population is not right, and it doesn't help us understand where we need to do better or set ourselves targets to see if we actually can do better.
Well, how did you gather the information? How did you know about this? Did you get it from government and medical sources, the hospital records, or did you actually contact people out in the public as well?
We've done both. I've been here nearly 3 years now, and this report, which we published in October, is actually the culmination of my work and that of my colleagues on Ireland since I arrived. Because when I came in, one of the first things I did was look to see what sources of health intelligence we actually had, and we didn't have any routine ones. And so I worked very much with colleagues, and I have a wonderful health intelligence team in public health now. And we said to ourselves, what would a set of information look like that would give us an overview of health on the island? And we looked at various examples from elsewhere. And in the end, we decided to see if we could basically replicate here something that they have in England and have had for some years now, which is called the Public Health Outcomes Framework, which is a data set of indicators around health and well-being that are routinely updated. And the beauty of going with something that looked like that English one was we would then be able to compare ourselves, benchmark ourselves against England, and not only against England, but against any local authority area within England. So having looked, as I say, at examples from elsewhere in the British Isles and further afield, we decided that trying to follow the English model was the way to go. And so over the last 2.5 years, my health intelligence colleagues have been working away to create something that looks similar. So we now have the Isle of Man Public Health Outcomes data set, which we have drawn on to provide the indicators in our report. And to give you some examples of how that's been done, obviously we have birth and death registrations here, the same as anywhere else. But up until 2.5, 3 years ago, the death registrations weren't being processed. Obviously, death certificates were being written out and causes of death were on them, but there was no routine collation and analysis of those to give you an overview of, what people are dying from in the island. So we now pay the Office of National Statistics across, and we don't actually have to pay them terribly much. It's quite a cheap service. They now get all our death certificates and they process them for us. So we can now understand how many people over a given time period are dying of the various causes of death and how that plays out across, age, death, and so on and so forth. So some of those things just weren't there before, but they are now. And as you say, we've also gone out direct to the public to ask for things that aren't routinely collected anywhere. And most of that is around the lifestyle indicators. So do people smoke? Do they drink alcohol? How much? How often? How much do they weigh? How tall are they? How healthy is their diet? How much physical activity do they take? All those sorts of questions we have to go out to the public and ask directly. And we do that through lifestyle surveys, which we've now set up and are doing.
Well, if you do a survey, what's the sampling rate? How many people do you ask?
I can't tell you off the top of my head because I haven't got the methodology in front of me, but we send out a sample based on census data and address data that's held by the post office. And obviously we then weight it to check that what we get back is representative of the population as a whole, which often it won't quite be because certain groups in the population are more likely to respond to surveys than others. So to give an example of that, middle-aged and older women are always overrepresented in responses because people in that group, and I'm actually one of them, we quite like doing surveys, so we'll do them, whereas some other groups perhaps don't engage so readily, and then we have to have ways of trying to balance that out when we analyse the responses.
I came across a figure, maybe this registered as 7,000 households. Does that ring a bell?
That does ring a bell, yep.
So these households initially are chosen at random?
They are, yes. But to represent, because it's done on the basis of household, we have to do it to represent the geographical spread. We can't get down into things like gender or age at that level because it is done on the existence of a property that has a postal address.
Now, most Western countries, certainly Western European countries these days, have reasonably good public health facilities and systems in. Now, you've focused on Public Health England there. Convenient, I suppose, and fairly inexpensive, but nevertheless, that's England. What comparisons have you been able to make, for instance, to, say, Denmark or Sweden or Belgium or wherever it may be, who also have a good public health record?
They do. I think there's an element of, if you do too much analysis, you get paralysis by analysis. And we could indeed look at who we can compare ourselves to the nth degree. And as I say, when we were deciding what to use as our framework for routine data collection, we didn't just look at England. We looked across the British Isles, so Scotland, Wales, Northern Ireland, Ireland, Channel Islands. We've also looked at what they do in Scandinavia and indeed what they do in North America, the US and Canada, and also Australia and New Zealand. And the Public Health England framework is actually the best in terms of its routine publication. Excuse me. None of the other countries within the British Isles at present publish something publicly that you can actually, as a member of the public, get online to and actually manipulate yourself to see the indicators and the places that you're interested in. The others aren't yet at that level of sophistication, I suppose would be the word to say it. Obviously, once you get into Scandinavia, you've got issues about language, because although you can often get translation, obviously the originals are not in English. And sometimes with Scandinavia in particular, they have things that are not in place anywhere else. And a lot of that would be some of their fantastic long-term registry-based studies. They have a fantastic track record of actually following groups in the population up for decades, because they are all registry based and they can actually do that. We can't. So to an extent, although that's wonderful stuff, we can't actually try and replicate it yet.
Right. Now, you have said that there was no such report before this one you've just released since 2004.
Yeah.
So how would people make decisions as to what to do without anything to base them on? Or was the information there but just not published?
The information was not there because it was not being processed and analysed. So it wasn't just a case of not being published. It was not there. As I said before, often I think decisions were made without being driven by that data and intelligence. They were done on the basis of perception, anecdote, people who felt very strongly that a certain direction was the right one to go in and were able to argue for that without using maybe the data or indeed, maybe other evidence. One thing that was done quite a lot was, as I said before, simple extrapolation from an English figure. So we have reports on record where people have said the prevalence of such and such in England is X per 100,000. Therefore, if we apply that to the Isle of Man population of about 85,000, we might expect number X. But actually, you don't know that. I have to say I have seen reports where even that level wasn't done, and the reports included tables that said, we think these things are the main problems and we'll indicate how big a problem it is by a row of stars.
So an element of guesswork in this then.
What can one say?
Yeah. Well, the independent, you call it an independent review, which I'm curious to know how it can be independent if your department has produced it. Was it produced we'll go back to who you had in the first place, independently for you, because it would be very difficult to be independent if it was your own officers producing it.
It has been produced by my own officers, working with me, obviously, to the agreed methodology. The reason it's called independent is because I, as Director of Public Health, publish it without any need for it to be approved by the Department of Health and Social Care or Tynwald or anybody else. And that, I think, is very powerful. The fact that this is the public health view. It's not the public health view as edited and approved by anybody else. So
this comes within a brief for you then. You have discretionary powers. You have, if like, a statutory responsibility to act in this way.
Yes, I
independently
do.
Of any political or other pressure then.
Yeah.
Right.
And it is actually set out in my job description that one of my duties is to publish this independent report.
Now, the report shows where, I'm using your words, where we need to look to drive improvement in health outcomes. Now, there's a whole range of matters in there. I mean, there must be a lot of others with the current sort of fractured system of government we have that you would like to get your teeth with and can't. That might be outside your remit. Is there much that is that way?
There probably is. I mean, the issue for me as Director of Public Health is that I am often in the position of trying to influence without having direct power. So, for example, health and well-being is related far more to the environment in which people live and make their choices about how they're going to live their lives than it is to health services. So that means that we need to get much better about getting health into all policies. That could be things about changing the environment when planning decisions are made so that we build in green space, spaces where people can interact and do things as a community together. There may be issues about how many fast food outlets we have and where those are and the quality of the food they're offering. I have no direct power to go and change those things. But I do hope, and I hope I already am, and I hope to expand on this, working with other government departments and indeed with, local authorities, communities, third sector organisations, politicians, to actually get everybody thinking about how they can build health into what they can do. But at the end of the day, I don't have a statutory power to compel anybody to do that.
Previous Chief Minister Alan Bell used to frequently coin the phrase silo mentality, that each department looks after its own and rigidly and almost jealously protects it. I mean, and what you're talking about crosses over quite a few departments.
Yeah.
How do you find, in this sort of today's current political culture, how do you find the cooperation between the departments? Are they still protective or are they open-minded?
I think at kind of top level, they're open-minded. And I think even going down below that, there are people who are very open to different ways of working. But I think where it gets difficult is that everybody is working within fairly tight capacity and resources, and they all have a day job to do, and they have to get that day job done. And I think, and this has been a historical problem, where there have been attempts to do joint working and joint strategic working, what has happened is it's kind of been dumped on top of everything else. So it never happens because people are actually being judged in terms of their work appraisals and how their line managers appraise them by delivering the day job that's in front of them at the moment. So nobody has the headspace to take a deep breath in and say, actually, we need to do things quite differently. How are we going to do this? How are we going to get there? And that's the bit that's difficult.
Well, looking through the range of topics which this report covered, and I appreciate there could be plenty of others, but it seemed to focus on about 5 in the main, and that was alcohol, drugs, smoking, obesity and mental health. Now, forgive me, but I'm getting a strong sense of déjà vu with all of those. These topics have been in the public domain and debated 10, 20 years longer.
Yeah.
With people looking for solutions, particularly alcohol and drugs, because we had a Chief Minister's alcohol and drug strategy for years.
Yeah.
And at the time, we questioned exactly how effective it was.
Yeah.
I mean, why are we dealing with these issues in today's society when it's yesterday's problems?
Yes, I fully accept what you're saying there, and I think we are not alone in finding these problems very intractable. It's a feature across the entire Western world. So to that extent, we're not behind the curve of elsewhere. I think, and we also have a long history of having strategies for all of these areas. I could have pulled them out and brought them with me if I'd wanted to, or you'd asked me to. And those strategies are not objectionable. They're full of, actually very good statements, but they are statements that I think I would classify as being in the realms of motherhood and apple pie.
The pies.
Yeah.
Yes. Oh, wait, yeah, good intent,
Exactly.
but not good practice.
Exactly. They are too broad. They will have sort of all-encompassing statements like, we will reduce overweight and obesity in children by X% by 5 years' time.
How?
Exactly. And that's the bit that's been missing. And I'm quite fond of saying that you don't have a strategy unless that has smart objectives, specific, measurable, achievable, resourced and time limited. And that needs to go with a detailed implementation plan, which has a budget, which has clear responsibilities, named roles or individuals who are going to be held to account for what they're going to do on this. And it's monitored and evaluated to make sure it's happening. And that was noticeably missing from all the previous strategies.
But all of those tasks which you've just mentioned, and they all make sense, cost money.
They do.
And now this is at a time when there's pressure, indeed on your department, probably on your division even, to cut its costs.
Yeah, you're absolutely right. And I think that is why, for a start, this has to be something that we are all doing together, to give a sort of vignette of how things have tended to be in the past. And I'll pick overweight obesity as a prime example. We know that what we really need to tackle is environments and behaviours so that people exercise more and they eat less. And that's got to be done at environmental and individual behaviour level. And it's got to be done with a focus on preventing, effectively to prevent children developing overweight and obesity, because once they've got to overweight or obese, that's going to go with them through life.
Now, you've raised a point there, because you're talking about the previous reports, all well-intentioned, but not really much practical outcome to it. But all of these ideas you've got and all of the things that you wish to pursue do rely on one other element, and that's the public's own cooperation and understanding.
Yeah, it does.
How do you get this through to them? Because people, none so deaf as those who won't hear.
No, and I think, again, this shows how we've learned as public health professionals over the years. When I first came into public health, which is 30 years ago now, we still had the old model of health education, health promotion. And the health education end of that very much was based on, if we tell people what they should do and that that's good for them, they will do it. Exactly. So the means of operating for that was very much around posters, leaflets, big campaigns, to get everybody aware of what they should do, and then they would do it. And as we know, they don't. So we don't do that anymore. And I have to say, I do sometimes get some flack for that. I get people saying, why don't you still have your health promotion resources unit? We need those posters and leaflets. Well, actually, no, you don't, because everybody knows what they should be doing. And that was really brought home to me when a few years ago now, I was doing a piece of research work with patients who were morbidly obese and were waiting to have the surgery, the bariatric surgery for their obesity. And we were doing, a focus group with them, really sort of asking, what has been your experience of how you've got to this point in your life's journey? And, what could have been done differently to turn that round? And they were saying, in fact, they made a joke of it. They were saying, we know everything we ought to have done, and we can tell you. We probably know it better than you do. And they proceeded to do exactly that and tell me all about the dietary advice, the exercise advice, etc. And they said, if we could do it, we would. Now, one could take a very sort of judgmental activity and say, well, it's you that's eating the pies, mate, so just stop doing it. But actually, it's not as easy as that. Most people who are overweight or obese know they are and would actually like to address it.
Is that figure I gave right? 61% of our society is basically too fat.
They're overweight or obese, yeah.
And that is what? Too much food? How much of that is genetic?
Genetic has a role in there. I think when you look at families, and often you do find that overweight or obesity runs in families, the major portion of that is really cultural. It's how they relate to food, how food is used as pleasure, getting together, etc., etc. Genetics does play a role. There are all sorts of interesting things that we don't know enough about yet around obesity. There's all the interesting stuff about hormones, so insulin, ghrelin, leptin. Yes, there is stuff that we will be learning about that, but I think the thing is we can't just sit back and say, oh, well, we don't know enough yet. Don't worry if you're overweight or obese now. Maybe in a few years' time we'll know more about hormones and we can do something different.
I've heard it frequently said that actually during the war years, when food was very limited, therefore people ate perhaps not as much and a little more carefully, people actually were healthier.
They were. Yeah.
So it's the supply for. You talked about takeaways. I'm surprised how many convenience shops survive. To be honest, there's that many of them. But we had the programme last week which referred to the food bank. and we were discussing it. What surprised me was the number of people they discovered didn't know how to process food and lived a lot on fast foods.
Yeah.
There's no cooking skills. Didn't even have a cooker in some instances in the house.
Yeah.
So there's a background issue, which is not just with the eating of it.
Absolutely. And that goes back to the wider determinants. When you mentioned there that there are people who don't even have cooking facilities, that links then into issues around homelessness or people who are only able to live in really very poor quality accommodation, where at most they have maybe a single electric ring to cook on. Some people may only have a kettle, and then, you know, all they can do is do a pot noodle or maybe boil an egg in the kettle. And clearly that's not acceptable, and it's not a good way to have to live your life, not only in terms of your diet, but also in terms of emotional and mental well-being, your ability to be an active part of society and everything else. So these are some of the issues that we need to address. And obviously it's no good telling people how they ought to eat if actually their circumstances mean that they can't.
Yes, now one of the problems, that's eating too much food, but one of the items that puts on weight, bound to put on weight, is consumption of alcohol.
Yes.
Or too much of it.
Yes.
Now, that was a second issue you raised, that you said that 21% of families, that's because, of course, one person with a drink problem affects the whole family in this instance, but 21% of families are affected by alcohol. That's a very high percentage.
Yes. Yes, about 1 in 5.
And this is down to children's performance at school in all sorts of ways, is it, that it's identified?
This was identified from the lifestyle survey, so it was actually asking people if they or their family had been affected by somebody's drinking.
Right.
Not all of those people will be alcoholics, the people who are impacting on families. Sometimes it's the way people drink, you know, the way family occasions get spoilt because a family member drinks in a particular way, which then leads to, you know, upset for others. So there are all sorts of different ways in which this can play out.
But it's a psychological effect on the family, but there's a financial effect as well on the family, because alcohol is not cheap these days.
No.
Culture, maybe? In the youth, is it bored?
Yes, although, I mean, one of the good things that's coming out of the surveys, and this includes the big youth survey that is done through the schools, is that actually young people are drinking less than they used to.
Right. But nevertheless, there's a work culture, isn't there, about drinking? People go to wine bars or wherever afterwards, and the glasses are big these days.
Yes.
So they're not getting just a little table glass this time. They're great big things.
The glasses are big, and there was a fascinating paper, I think it's in the Christmas issue of the British Medical Journal. It's absolutely brilliant. It's been picked up by some of the papers, the mainstream papers. And basically somebody has actually done a historical tracking of the size of wine glasses over the years, and they go back to the 18th century when a wine glass was a tiny thing. I forget the figure they actually say for volume, but it's, you know, sort of like the size of a single spirit measure, 25, 30 mils, something of that sort. Whereas now, of course, we have those wonderful big, and I have to admit I've got some at home, wonderful big red wine glasses, which would have a capacity, if you filled it to the brim, of probably 250, 300 mils. You're probably not supposed to fill it to the brim. The idea of it is you put wine at the bottom, you keep it warm in your hands, and you get all the wonderful, you know, the smells and all the rest that comes off it. But I think the tendency is if you've got a big glass, you slop wine in and you lose track of how much you've drunk. And that's always a risk. I
read an article a few weeks ago to say that there's a campaign on in France to stop parents feeding small children wine at the meals. And the argument behind that was that if they did it that way, they would then take it as a fact of life and not necessarily kick over the traces or have to go out and use it as whatever they did use it as. And they discovered that this singularly failed. In fact, it hooked them on it.
Right.
Yes. So in other words, there is a cultural thing in this as well.
Yes.
Within the families too.
Yes, I think that's very true. Yes, I mean the advice that is given across the UK is that children shouldn't be encouraged to drink, you know, with the family or any other way until they're at least 15.
They used to, in some countries, well, France again, I think, give a very small amount of wine in with the children and their nighttime drink to send them to sleep. Quite common, apparently. You can see the effects that had.
Yes.
Though alcohol is used for something else, though, isn't it? Some people who have certain psychological problems or mental health problems use it to self-medicate.
Yes.
And that is something which, well, we've discussing the question, of course, raises out of this. What do you do about it?
There are a number of things that can be done about it and that need to be done better, that we're not doing well enough at the moment. And one way that has actually got a very good evidence base behind it is just for health professionals and indeed others who come into contact with people, just to try and explore raising the question about how much somebody drinks and whether they would like to think about it. There is a methodology for this. It's called identification and brief advice. And you can train a whole host of people to do it. It could be GPs, practice nurses, ambulance crews, fire officers. It could be people working in voluntary organisations. It could even be hairdressers. And it's just to give them the techniques and knowledge to ask a fairly open question that just lets somebody begin to think. Now, if that person either doesn't have a problem or is not in a place where they're even wanting to think about it, then they don't have to go any further. But it's done in a very open way, so it's not sort of, Mr. Jones, I think you're drinking too much. Because actually that sort of approach will get resistance. No, I'm not. It's none of your business anyway. People need to understand how to do it in an open way. You know, have you thought about... as I say, people who aren't in a place where they want to think about it will say, no, I haven't, it's not a problem.
For somebody to get help, for instance, when they're fairly well hooked on it, whether they're alcoholic or they're binge drinking or they're just drinking too much, it's no point telling them, is it? They have to ask for help.
But they need to be signposted to it, and that's what this IBA, the Identification and Brief Advice, does. It raises the issue with them and begins to explore with them whether they're in a place where they're ready to think about receiving help, because there's no point in referring people for help if they're not actually motivated to engage with it.
And to accept it.
So the idea is that you raise with them, you explore with them whether they are in the right place to actually start making a change, and then you signpost them. You actually say, you know, here's where you can go. You could even take it a step further, and in fact I think it's the ambulance service in Yorkshire, because the ambulances get called out a lot to people where alcohol is actually the root cause of the call. And what they've been doing in Yorkshire is doing this identification, so having that chat and opening things up for the person. If the person actually responds in a way which says, yes, I think I would like to do something about it, the ambulance officer not only gives them the signposting, tells them where they could go, but they will also say to them, would you like me to pass your details to that organisation so that they can get in touch with you? And if the person says yes, then that's what the ambulance staff do, and then it gets followed up.
And is it working?
It is. It's working very well. I mean, you never expect more than about a third of people to actually go through and make a change when you do any of these motivational interventions. So you're never expecting, you know, massive change, but it's an appreciable and significant one.
Okay, well, look, we'll take a pause in our conversation here to return after the commercial break, which is around about 3 minutes.
Join Tim.
Dr. Henrietta Ewart is our studio guest on today's programme, and she's the Director of Public Health for the Isle of Man, and last month published a report covering a wide range of public health issues, the first report since 2004. Well, as we said before we went to the break, there are a lot of topics here which we have a tremendous sense of having seen before, still within our society, and one of those is tobacco. And as you'll figure that 69% people would like to quit, well, obviously that would indicate that it's still a very addictive process. I mean, the next question, same question as before, what can we do about that? If all those people would like to do something, what do we do?
Yes, well, we have a specialist stop smoking service which people can contact and get in touch with. And also some of the GP practices also offer specialist stop smoking advice. So there are a number of ways people can get in touch and get help. There is very good evidence that the specialist services do increase your chance of quitting compared to just trying on your own. So it is a very tried and tested approach, and anybody out there that's thinking they might like to quit, do get in touch.
How about these electronic cigarettes you see people sucking? Do they work?
They are still comparatively new, so the evidence is still accruing on them. There have been concerns about possible harms, either due to the things contained in the vapours or because potentially they could act as a gateway for getting non-smokers, particularly children and young people, into tobacco smoking. Now, that gateway issue has not proven to be the case as yet. We're not seeing any evidence here or anywhere else across the British Isles or wherever else we've seen data from to suggest that they do work in that way. There is a varying level of regulation on what's contained in the vapour. So the risks are that there could potentially be harmful substances in the vapour, but regulation is increasing on those cigarettes, on those e-cigarettes, so that is unlikely to be an issue. The current estimate, and it is only an estimate, is that e-cigarettes are about 95% safer across all the parameters than smoking tobacco. And there is some evidence that they can either act in harm reduction, because if people vape instead of smoking tobacco, they are getting the benefits of not smoking tobacco with all the tar and all the rest of it that goes with that. And some people do find that they can use e-cigarettes as a way to giving up completely.
If a product was so dangerous as this and was on the market in any other way, its sale would be banned. Yet here they are, still openly for sale. And of course, many governments in different countries have shown a great disinclination to do too much about it, because there's a huge revenue comes off it into the public kitty.
Yes, indeed.
But we've got here now covering up displays, messages on packets, pricing them very high. It doesn't seem to work, does it?
Actually, it has worked in that the rates of smoking have come down massively. We now run at about 14.5% of the adult population being smokers. That's the best, I'd say the best it's ever been. It's probably the best it's ever been because we don't have the robust data for the Isle of Man. Certainly it's in parallel with the figures for England, and their figure is certainly the best they've ever been. It's come down from rates that used to be over 40%, 50 years ago, down to about 20% 10 years ago. So there is a consistent fall. But yes, if it was a new product that came out now, it's unlikely that it would ever get to market. But we are where we are.
Right. Now, that's the user of a cigarette, if you like, or the addict, or what it is really, isn't it? What about the families? We talked about the effect on families of alcohol, but there must be a knock-on effect, a collateral damage with smoking as well.
Yeah. Very much so. And of course, children are the most at risk from being in a household with smokers. And the evidence is very clear that it increases their risk of respiratory infections, asthma, and so on. So really, anyone who is in a household with children should think very carefully about smoking.
When I was a young man, I used to get asthma as a child. My parents both smoked. And when I went away to the UK, I went into an environment where nobody smoked and it stopped.
Right. Yeah.
So there's evidence.
It's a very strong demonstration.
Yes, yeah. In this at all. But we've got cigarettes, we've got the drugs we haven't talked very much about, because it does seem that although there's serious concern about drugs in the Isle of Man, the percentage of people involved in drug use in the Isle of Man is quite a lot smaller than the other things.
Yes, I think that's a fair comment. Clearly, there are drug-related harms, and there are people who are either bearing the results of those harms themselves because they are users, or family members who do. We certainly have a cohort of long-term opioid users, and that's a feature that is found across the Western world. It would be the case in all the jurisdictions in the British Isles and in Ireland and the Channel Islands.
As you're making these comparisons for other matters, can you make comparisons there? How do we compare, for instance, with England in some sort of percentage of usage like this?
We're very similar. we're very similar. We have a higher rate of drug-related deaths than England as a whole does. Our rate actually looks very similar to the Northwest, and that is because our routes of supply largely come in from the Northwest. And where there have been issues around supply of heroin in particular, either because it's been of higher purity than used to be the case, or because it's been cut with other drugs such as fentanyl, which are higher risk, we have experienced deaths amongst users on island which relate to supplies that they actually got from the Northwest where they've had similar problems.
Yes, so we're back to the police and others now tackling it, but it's not easy, is it? And
no,
all of this is, of course, but people are determined. That drugs take us on to mental health to a great degree, doesn't it? Because there is a knock-on effect there in many different ways. And your report terms and or focuses, I should say, quite a lot on bullying.
Yes.
I mean, I would have thought with mental health it might be other issues, but there's 3 or 4 sections where you concentrate on bullying.
Yes, I mean, I think bullying is very much an influence on mental health. I think because it often affects people when they are children and young people, it can lead to problems which stay with them throughout their life, and poor self-esteem would be one of those. So I think when it comes to bullying, it's something that needs to be tackled in terms of making it very clear that it's a behaviour that is not tolerated. And there is also something about building resilience in children and young people, and schools are doing quite a lot around this already, and I think it's one where we could do more, so that people do not become victims of bullying. They are resilient enough to push it back. It shouldn't happen, and I think we've got to take an absolutely firm zero tolerance stance on that. But if we can give people the resilience to combat it as well, then that's, a double pushback on that sort of behaviour.
Something else is nothing new. I can remember back to my school days, there were always big fellow wandering around who are usually fairly dim, and the only way, as you say, they can bolster their self-esteem was this sort of behaviour. But it was almost a fact of school life. I don't remember too many people being depressed or worried about it.
Yeah, I think, the way we react to things has changed. I think we're more open about things. I think this is something about, the culture of the stiff upper lip. These things were there in the past, and people suffered as a result of them, but they suffered in silence. They maybe went on to have problems, with the self-medicating with the alcohol, as you touched on before. And actually now I think we're getting much better about being open about them, and that should lead to us being able to address them and prevent them much earlier on.
We're talking about a school environment here, but it's outside school as well, isn't it? It's in other walks of life.
Oh, yes. Yeah.
Now, we're almost at the end of our section of this programme now, Henrietta. We have a man in line coming up a little later, and we've only touched on a few of the many subjects that your report has touched on. So how would you like to join us on the man in line, and we can continue our conversation, hopefully, with those people listening joining in?
I'd be delighted. Thank you for asking me.
Right, very good. Well.